Greetings, ladies and gentlemen. My name is George Mensah. I'm a heart specialist by training, and I currently serve as the director of the Center for Translational Research and Implementation Science at the National Heart, Lung, and Blood Institute, which we call NHLBI, which is part of the United States National Institutes of Health, NIH. And I want to welcome all of you on behalf of the Journal of the American College of Cardiology, the Institute for Health Metrics and Evaluation, IHME, at the University of Washington, and the National Heart, Lung, and Blood Institute, the three co-sponsors of this Global Burden of Disease webinar series for Africa. Now, as you all know, cardiovascular diseases remain the leading cause of disease burden in the world. The number of deaths, as well as the measures of disability attributed to cardiovascular diseases, continue to increase worldwide. Unfortunately, though, many people still mistakenly believe that cardiovascular disease is a disease of old people. However, in 2019, this is part of the Global Burden of Disease study, cardiovascular disease was the underlying cause of more than 6 million deaths that occurred between the ages of 30 and 70. So we know that the majority of these deaths are attributable to modifiable risk factors, that are risk factors that can be prevented, risk factors that can be treated, and risk factors that can be controlled. So there's a real need for a renewed emphasis and investment in clinical and public health programs that target these modifiable risk factors, programs that promote healthy aging across the lifespan, and programs that reduce disability and disparities in premature death due to cardiovascular diseases. Currently, we all know there is inadequate awareness, there's inadequate promotion of ideal cardiovascular health, and the promotion of healthy aging from children all the way to the elderly. So we need to improve sharing best practices, sharing policies that will lead to implementable approaches so that we can reduce this burden and avoid the dangerous patterns, for example, of alcohol consumption, uncontrolled blood pressure, smoking, and also promote the adoption of diets that are low in added sugar, in sodium, salt, and harmful fats. So effective and affordable strategies remain under use. We know that. That's what we're going to try to address today. Now, we are not going to rehash the numbers and the estimates that we published in the Global Burden of Disease GBD 2019 study, but we want to focus on the key themes that are really relevant. And I'm really pleased to say you are in for a treat. We are very, very fortunate to have with us 4 outstanding, distinguished clinician scientists from the African continent. And in the interest of time, I'm only going to highlight just a sentence or two about each one of them so that we save the time for the conversations we're going to have about the burden of cardiovascular diseases in Africa, and importantly, what to do about that burden. So I encourage all of you to review their CVs, their resumes, and the background bios that they've provided. So now, very briefly, let me introduce our panelists. And going in alphabetical order, we have Professor Aime Bonny. Professor Bonny is a professor of cardiology at the University of Douala in Cameroon, where he also specializes in electrophysiology, that is diseases and disorders of heart rhythm. He's also president of the African Heart Rhythm Association. Welcome to the panel, Professor Bonny.
Thank you.
Thank you. Next, we have Professor Ana Olga Mocumbi. Professor Mocumbi is an associate professor of cardiology at the University Eduardo Mondlane in Mozambique, where she is also the head of the Non-Communicable Diseases Division at the National Public Health Institute of Mozambique. Welcome, Professor Mocumbi.
Thank you.
And we have next Professor Mayowa Ojo OWOLABI. Professor Owolabi is a professor of neurology that is the field that encompasses stroke and diseases of the brain and the nervous system. Professor Owolabi is also the Dean of the Faculty of Clinical Sciences at the University of Ibadan in Nigeria. Welcome, Professor Owolabi.
Thank you very much.
And then last but definitely not the least, we have Professor Karen Sliwa. Professor Sliwa is Professor of Medicine at the University of Cape Town in South Africa, where she's also Director of the Cape Heart Institute and currently serves as the past President of the World Heart Federation. Welcome, Professor Sliwa.
Thank you.
So please join me in welcoming our four experts. And I'm going to start out by saying that the major themes we're going to emphasize are the major risk factors that I mentioned, the burden and the trends. We're going to highlight high blood pressure, obesity, diabetes, and the implications that all of these have for cardiovascular diseases. We don't want to leave out the health systems and systems level factors. Those are the issues of access, of affordability, of availability of medicines, for example. And we also want to touch on the social and environmental determinants of health and disparities. And we'll conclude with some comments on research and the policy implications. So let's go ahead and I'll call on you, Professor Bonny. And just to be sure, we are all friends here. So we're going to go with first name. So Aime, you know that the Global Burden of Disease 2019 study showed that the burden of cardiovascular diseases that can be attributed to risk factors continues to increase worldwide. We know, however, that the global trends don't necessarily equal the local trends in Africa. So, Aime, are the factors, those major risk factors also increasing or decreasing in Africa? And are the other trends different for young people compared to old people in Africa? What can you tell us about these trends in Africa?
Okay, in general, I would say that the global trend in Africa is also increased, as is increased in the rest of the world. But this increasing trend can be explained maybe partly by the fact that we have in Africa the increasing rate of physicians and specialists of cardiovascular diseases that can, of course, use all diagnostic tools and setting up campaigns to diagnose unknown people with cardiovascular disease or risk factors. So this is one of the main reasons to observe this trend increase in Africa. And the second reason is that the lifestyle in Africa change regularly. People move from the rural area to urban area with very high rates of unemployment, stress, tobacco, obesity, and other risk factors. So definitely, although we observe the disparities among sub-regions in Africa, but in global, these risk factors increase. I can give you to finish one example regarding low physical activities. Low physical activities, although is less in low-income countries and in Africa compared to Western countries, but we observe a quite variability differences among regions. In Central Africa, we see that we have as dailies due to low physical activities about 215 compared to West Africa, where it's very less dailies, less than 120. And this trend is fewer in East Africa with less than 80 dailies. So it's the different trend, but this different trend also maybe can be attributed to the fact that we don't have the same health policies and the same means to find out all these risk factors, because the income in the health policies is not the same in all regions and in all countries in Africa.
That's excellent. We will get back to some of these socioeconomic income geographic issues, but it's really good to know the patterns and the differences that you've highlighted. Mayowa, let me call on you because what Aime just said very often immediately gets us thinking about heart attacks and heart disease. But what about stroke? What are the primary drivers for stroke in Africa? And are they also increasing or decreasing, for instance, when you think of high blood pressure? Mayowa?
Yeah. Thank you very, very much. Hypertension remains the #1 risk factor for stroke on the continent. In fact, it accounts from the Siren study, and there's so many other publications we've had, so many, apart from the one we have in the Lancet, we had so many other publications from the Siren study on ischemic stroke, on hemorrhagic stroke, on stroke outcome, and all of that. Hypertension remains the king, is the premier risk factor, accounting for between 80 to 90% of population attributable risk, and occurring in up to 80% of those with hypertension. And also is also the topmost risk factor, whether it's in males or in females or in the young or in the elderly, it's #1. And therefore, even in the young, it accounts for a high proportion of hemorrhagic strokes. So hypertension remains #1. But surprisingly, there are other risk factors that are also very, very important that we were able to unravel as drivers of the stroke burden in Africa. Mind you, NCDs, particularly cardiovascular diseases, are now the leading cause of mortality in Africa since 2019. So it's really has turned the corner. Everybody usually thinks, oh, Africa is infectious disease, but that has changed. And little wonder, hypertension affects 1 out of every 2 or 3 adults. You know, from the share resources, from what we did across the H3 Africa Consortium, covering more than 55,000 people, 13 countries, you know, hypertension remains something that is very important. Undetected many times, and not treated, or even when treated, not controlled. Only 7% of those who are hypertensive are detected, treated, and controlled. And so it's not surprising that hypertension, that stroke remains a very huge problem. But there is also dyslipidemia, which surprisingly is also silent, but is also a very huge burden. We never knew about this before. We didn't expect it. But it's happening.
And you're talking about bad cholesterol there, right?
Absolutely, absolutely. Okay. Of course, there is also diabetes. There is also obesity, and then we observed a very, very interesting relationship between obesity and hypertension.
Well, let me hold you there. Let me hold you there for a minute.
All right, thank you.
I want us to spend some time on obesity later on, but this is really important. You mentioned something that made me think about women when you mentioned some of the differences we've seen in females. But Karen, please come in here. You know, when we talk about heart attack and stroke, they are just as important in women as they are in men worldwide and also in Africa. But what do we know, and what else should we worry about when it comes to cardiovascular diseases in women, especially women of childbearing age? Karen?
Yes, I think there is a specific situation for the African continent and other low to middle income regions, that there is, we don't have health system who pick up heart problems early. So what is happening that women might have rheumatic heart disease, they might have unknown congenital heart disease, like a small atrial septum defect, other congenital heart disease. They might have hypertensive, they don't know. And what happens when they're pregnant, because in pregnancy, it's like basically like a stress test. You increase your cardiac output, it actually almost doubles. So undiagnosed cardiovascular disease becomes unmasked, and women very typical present when they are pregnant with a cardiac condition which they had before. So that is important to know, because the obstetrician who's dealing with women who are pregnant, typically in the second trimester, suddenly has to deal with the fact that they have a cardiac condition. And that's quite unique to Africa and other low-income regions who don't have a healthcare system who pick up cardiac problems earlier.
That's really intriguing. We need to pick up on this a bit later. But Ana, I really want you to jump in here. We talked about the special case of women and what we need to know. How about children and young adults? Because very often we don't even worry about children as if they're going to live forever. What should we know, particularly school-age children and the link to cardiovascular diseases?
Thank you. Regarding children, first I must say that in our continent, children are a very important proportion of the population. So in countries such as Mozambique, for instance, we still have a very high fertility rates, despite efforts to disseminate the importance of family planning, etc., we did not reach a balance, and countries continue to grow. So Mozambique, for instance, have more than half of its people under the age of 17. And this puts a very big burden into the education system, into the health system. And one of the problems that we have in low-income countries in Africa is the lack of data. As my colleagues have mentioned, lack of early diagnosis, proper diagnosis, the means, the access and affordability to a correct diagnosis of cardiovascular disease and other risk factors in general makes them silent. And because of this, children have traditionally not been prioritized for non-communicable diseases. However, as we mentioned, congenital heart disease affects African children in the same rates of any other countries. We have research showing that. On top of that, we have specific diseases related to poverty, diseases related to this low access to health systems, such as we just mentioned, untreated congenital heart diseases, but we also have the chronic complications of infections. So we have infections such as tuberculosis, such as schistosomiasis, HIV itself, because in some parts we still see HIV in children in Africa, that have chronic complications that affect the heart and the vessels. And because of this, the diversity of conditions affecting children is also very big. In terms of trends, like my colleague said, the capacity to diagnose increases the knowledge that we have. Probably not the incidence or the prevalence itself, but the knowledge that we have. And we are now more aware of what we should do and how we should focus on children. So I would say that specific aspects are also to end linked to the environment. As you know, we have specific determinants that are related to the environment, not just infections, but also pollution, indoor air pollution in particular, which is a known risk factor, but is not yet studied enough, particularly in children, to be able to know what role this risk factor is playing in the right heart failure that is very frequent in Africa, in the problems that we have related to the muscle, the heart muscle pumping weekly, that we suspect, but we don't have definite answers.
That's excellent. That's excellent. You know, you're mentioning heart muscle made me turn and immediately look at Karen, because heart muscle diseases are an important part of cardiovascular diseases, and we don't usually address them. Karen, what would you want to tell us, especially given the risk factors that we've already mentioned, including obesity that was mentioned? What are the impact of these on not just hypertensive and obesity-related cardiomyopathies, but heart muscle diseases in general? What should we know and learn from this global burden?
Yes, I mean, in Africa, or many regions of Africa, the so-called idiopathic dilated cardiomyopathies are more common than in other parts of the world. And it's not really known why that is. There is a study ongoing at the University of Cape Town led by Professor Ntusi. It's called the IMOTEP study, which is looking at the genetics of the cardiomyopathies, and they collected more than 1,000 cases. And the study will also be expanded. But what we assume is that some of those dilated cardiomyopathies are really often diagnosed in people in their 30s or early 40s or even younger. Some are genetic based, we know that. Some are most likely post-viral myocarditis, which also appears to be more common. There is some limited evidence that this is more common on the African continent. And some will be, it's a wide range of other reasons why you have what belongs to the group of cardiomyopathies, which obviously is a hypertrophic cardiomyopathy, endomyocardial fibrosis, other restrictive cardiomyopathy, and peripartum cardiomyopathy, which is also particularly common on the African continent. So all this falls into the group of the cardiomyopathies. So it's a mixed bag, but it is a common diagnosis. And if you look at studies like the CVDs study, which collected information on consecutive patients presenting with acute heart failure, you can see that it was the third common reason to present with acute heart failure in this study on the African continent, where 9 countries participated. So it's definitely more common diagnosis than, let's say, in Germany or other parts of the world.
That's excellent. In fact, you just reminded me that when you mentioned Professor Ntusi, that you and Ntubeko published a 2-part series in the Journal of the American College of Cardiology on this specific issue of cardiomyopathy in Africa, and I would encourage others to take a look. Aime, you know, you mentioned at the very beginning the importance of some of the geographic differences, that some of these trends that we see are different for different parts of Africa. And I was just reminded, as we talked about obesity, what we see in North Africa and the Middle East for obesity and what we see in Southern Africa for obesity tend to be different, at least in terms of magnitude, what we learned from the GBD study from East, West, and Central Africa. What can you share with us, just very briefly, in terms of some of the geographic differences in these major risk factors that are important for us to know? Aime?
Yes, definitely. Obesity has all other major risk factors, has a different burden in different sub-regions. But in general, I want to mention that the obesity in women, it's more predominant, more concern, as we have, we know that women in Africa has 2-fold more obesity prevalence than men. The main reason for that is the low physical activities in women, and also maybe the dietary, the food consumption in some region is part of explanation of that. But the obesity also depend of the level of education of population, the level of poverty in that population, and country with more balance, more investment in all health policy have the rates of obesity lower compared to other parts. In that reason, I can say that the Central Africa sub-region, which is the more poor sub-region in Africa, claim the more rate of obesity compared to all other regions. So obesity is explained in part by the poverty, and that is very important to address a question of increasing the level of life in all these population of Africa.
Reminds me to highlight that, you know, very often when we talk about these risk factors, whether it's high blood pressure, hypertension, or hyperlipidemia, or diabetes, or obesity, we tend to focus on individuals. And in fact, very often we blame individuals. They don't exercise enough. They don't eat right. But we all know, just as Aime pointed out, there are social and environmental and economic conditions that predispose to this. There are also systems level factors, the health systems factors. And Mayowa, let me call on you, and I'm going to ask all of you to give me some very brief responses so we can cover a little bit more before our time is up. But what are some of the systems approaches in Africa that we have to emphasize, especially when it comes to thinking about these systems and stroke? What would you say, Mayowa?
Absolutely. I would like to approach this by saying we should use the behavioral change wheel model, as well as implementation science cycle. In summary, we should not only think about the individual, we should think about the system, we should think about the community as well. So we should think about motivation, we should think about capacity, we should think about opportunity whenever we're talking about behavior. It's not enough for the individual to be, first of all, aware, because that's also a major problem which we can solve using social media, using a multi-sectoral approach, including the educational system, including the food value chain, including LDCTs, a lot of things that we can do, you know, including providing opportunity for people to screen themselves or to be educated about cardiovascular health in every encounter that they have, whether it's social encounter, whether it's religious encounter, whether it is educational encounter, whether it's at home, whether it's at work, whether it's through videos, through cartoons, through sports, whichever way, we really need to let people know about this, because this is something that affects everybody in the end. So that's number one, is raising the level of awareness. And then addressing the social factors. Sometimes, you know, it's believed that obesity is a sign of good living. We need to reverse that, you know, those cultural factors, to let people know that a healthy weight prevents hypertension, prevents dyslipidemia, prevents diabetes, prevents stroke, and so on and so forth. So that's very important. Then the food value chain is extremely important, just like cigarettes. If cigarettes is not available, people will not smoke, you know. So if unhealthy food is promoted, processed food that has a lot of salt, fatty food, or fast foods and things like that, you know, they should actually be there should be disincentives against such. Whereas things like green leafy vegetables, which we found to our own surprise, and that's something very extremely common in Africa. green leafy vegetables protect against stroke. Regular consumption. In fact, we have a paper that has just been accepted and is going to be published in the next couple of days in the European Journal of Preventive Cardiology that shows that using data from about 13 countries covering more than 30,000 people across Africa, we found that those who consume vegetable, about at least 12 servings of vegetable per week, are unlikely to have hypertension. So primordial prevention is important, primary prevention is important, but it's a complete ecosystem that involves everybody, involves the kind of food that is grown, that is sold in the markets, you know. And then when we talk about exercise, also safe neighborhoods, very, very important, walkways, very, very important, you know, and then encouraging and incentivizing physical activity. Those are all very, and integrating this into the schedule at home, in schools, in religious activities, and in all the various phases of people's encounter. So it's very important. And it must be done across the entire life course.
Yeah, that's very comprehensive, the entire life course approach. And I'm sure if we allow you, you can talk for another hour about this, but I think you highlighted it very well. This is very important. We really need to move away from blaming the patient, encouraging them, incentivizing them, motivating them, and also working at the systems level. And Karen, it's very clear that no one sector can do this alone. Even governments can do this alone. And research funding agencies can't do this alone. But I'm going to call on you, wearing your hat as the past president of the World Heart Federation. What can professional societies like the American College of Cardiology, the World Heart Federation, the Pan-African Society of Cardiology, what can these professional societies do to really help move the needle and support patients and their families, and really stop blaming individuals? What would you say, Karen?
I mean, it is really what the big societies, what their role is really to influence the big food producing companies or to come up with policies of taxation of unhealthy food products. If you go to rural Mozambique or Uganda or even here in Nigeria, people eat vegetables, fruit, they drink juices, they actually eat reasonable, healthy. Unfortunately, in countries like South Africa, you have a big influx of companies who market very aggressively unprocessed food, very unhealthy food products, which are not part of the traditional diet of most African populations. So I think the role of those societies is really to come up with high taxes like we have with tobacco, and ideally even restricting influx into countries. That's quite radical, but I really think I don't see any reason why very processed food products should be able to be purchased in northern Mozambique. Why would they? They kill people. They kill the food chain. They kill the production of other food, which creates employment for poor people. So I think societies have a very big role to play, talking to policymakers and tackling those global issues of marketing processed food as something which you see. It's also the image. If you are standing there with a hamburger in your hand or a Pepsi Cola, you're seen as you're marketed as an affluent, advanced, modern, westernized young chap. That image has to change. And that, I think, is really the role societies should take on. Nobody else can do that.
Excellent. Excellent. That's a call for a very comprehensive, multi-sector, multidisciplinary approach, where we also leverage social sciences and social media to really address and change some of these images. In the last several minutes that we have, let's touch on, go back or at least mention again the social determinants of health that we mentioned, because it's really also very relevant. And Anna, I'm going to call on you, especially when we think of rheumatic fever and rheumatic heart disease, and in children, the social determinants play a very big role. What do we need to know and do, particularly when we think of children, school-age children, in trying to prevent these diseases of poverty, as you put it earlier?
So I would say that we briefly mentioned that all types of prevention are important. However, I would go back to what my colleagues have said already. First, health literacy. And all this discussion on role models, for instance, role models linked to alcohol, it's very common, this aggressivity that Karen was talking about. It's really a problem because we need to educate our communities from very early stages. And investing on health literacy in children and adolescents, it's now a priority for Africa. We cannot continue to have the same rise in diseases, continue to have a population mostly of young people, and continue to lose these young people to premature mortality by cardiovascular disease and other non-communicable diseases. So I think that is the first one. Also, I think that we need to come up with models of integration to be able to use efficiently our few resources. We need to be a lot more efficient than we are, and we need to compete for efficiency, I would say. And this is really something that we need to learn more about, the science of integration. No one is very sure on how to integrate. We all talk about integrating care, integrating infectious and non-communicable diseases. So I think that there is need for an investment on how systems, models of integration that are suitable for countries that are facing economic challenges and challenges of lack of resources. We have some experiences in the continent on task shifting that have worked. It's another area where I think we should invest more to be able to use more the resources that we have and the few educated people to really spread knowledge about prevention and knowledge about the major risks that our communities are facing.
That's excellent.
So, yes, I would say that for me, this attempt to solve our problems based on what is already known, but using solutions that are targeting the very specific problems that we have is one of the biggest priorities that we have in our continent, to protect our children and to protect our young people.
That's good to hear. Sounds like you're making a case for also investing in research about dissemination science, about implementation science, how we come up with strategies that will be most effective in integration. How do we do that? And that's really key. I'd like us to finish off by extending this discussion into some of the research opportunities and the implications for clinical and public health practice, as well as research. And very, very brief responses, because I'm going to come back to all of you and ask again the one message you want to give about the research that we need to do. But Aime, let me ask you very briefly. A lot of what we've heard, it's usually very easy to understand within the context of either hypertension or heart failure or acute myocardial infarction or stroke. But when it comes to arrhythmias, and I know you've recently published quite a bit on the spectrum of heart rhythm disturbances, what do we know about social determinants and the impact on the spectrum of heart rhythm disturbances? Atrial fibrillation and flutter and ventricular arrhythmias, do they also have the same drivers in social determinants as we see in hypertension and heart failure?
Yes, of course. All these cardiac conditions have the same trend and social determinant. We can say that in the field of arrhythmia and cardiac conduction disturbances, which needs to implant a pacemaker, we observe that first, about 20% of African countries do not offer pacemaker implantation in their country. So people died because of the absence of any resources, any services to implant pacemaker. Globally, even in the other country where you have at least one hospital implanting pacemaker, the access is very challenging. Some people have to travel from the rest of the country to come in this country. Even when they arrive, the price of procedure is too high to be affordable. That's why we observe that the rate of implantation is higher in those countries where pacemaker implantation procedure is free of charge from a patient, and also in those countries where the price is regulated by the government. Because in some countries is a free price depending on the physician who provide this procedure. In other countries, there is the government regulation, and the government sponsor this procedure. Regarding atrial fibrillation and flutter is very anticoagulation challenge in Africa. Many countries use only VKA for that with this difficulty to monitor INR, as we know, and those are very rare. Even we have NOACs in almost all countries, but the price of those limits the use of these new anti-oral anticoagulants. So we have the trend toward the better management of arrhythmia in Africa, with more and more countries with EP services, electrophysiology and ablation procedure. But in general, the gap with Western countries is quite important. Needs to be reduced by
Excellent
the involvement of
a
government.
Clear emphasis on the importance of regulations, importance of health policies, and importance of really providing support to patients and improving access, affordability. Let me turn now to the final segment where we get your thoughts on the research that is needed. I think all of you have made a very, very strong case that we know enough to address the burden of cardiovascular disease in Africa. There is a component of research that still needs to be done, some compelling questions that we need to ask. And Karen, let me begin with you. When you look at the GBD 2019, it's really a wonderful platform that allows us to produce these health estimates, to track, to benchmark the progress that we're making. However, there are large investments that are still needed in order to improve surveillance, including expanding vital registration in many countries, reliable electronic health records that may not exist in a lot of places, and also health surveys in all countries. I must admit, South Africa has been an important player on the continent in innovating these systems. Where do you see opportunities for really widespread scale up and spread across Africa when you think of these important systems and the research that is needed to advance them?
Yes, I mean, 2 points I want to make. One, you mentioned in the very beginning that we document cardiovascular disease from 30 to 70. And I think there's a fundamental problem with it because many cardiovascular conditions on the African continent are in people who are younger than 30, including pregnant women, people with rheumatic heart disease, and children. So I mean, I think we first have to change our criteria to be suitable for this continent. Secondly, I think we have to, the physicians, cardiologists need to interact with the politicians. Health ministers, they have a lot of different conditions they have to take care of. And if we all don't speak up and create awareness how important data are and cardiovascular data are, they will not invest or assist in a system where this information is collected. So I think it's also partly our own fault. We sit in our own silos. We talk to each other like now, but we have to invest, let's say, 10% of our time to translate the messages to the policymakers, engage them, invite them, reach out. Unfortunately, that change, you know, politicians change. So it's not something you do once. You have to, every 2 years, reach out again. And I think that perhaps should be taught even at university levels, that we have a responsibility to work within our society. We are not just a doctor for one patient. We have a responsibility of interacting with the community, with healthy people and policymakers.
That's excellent. A real need for us to recognize that we can't do this alone. And we have to use the data to inform our policymakers so they bring in the resources that are needed. Anna, let me call on you to address one point that we haven't made, because this cardiovascular burden, very often it doesn't show up in isolation, right? So we have our patients, for example, people living with HIV, they have cardiovascular complications, and I see you're part of the NIH-supported HLB Simple. Very, very briefly, what could you tell us about some of the research that hopefully can help make some progress in the way we address the prevention and control of cardiovascular diseases in people living with HIV? Anna?
Thank you. I think that multimorbidity is really a major problem. And it is not just the confluence of several risk factors that affect our population, but also those health systems problems we have been talking about, and the lack of data and lack of prioritization. I think that one thing that we can learn from the HIV community was their capacity to empower people, to have patients, to support the efforts that Karen was just saying that we should all aim to do. And I think that a lot of research can be done, and high quality research can come from the continent, which unfortunately has a high prevalence of HIV. And we have been learning a lot about how we should integrate the care for our patients, because has access to medicines for HIV improve in our continent. Our populations are becoming older and older. And all the risk factors that are linked to the medication for HIV, the infection itself, and the coexistence of high prevalence of hypertension, for instance, in our populations, are becoming to represent a very high burden to the program itself. So we think that more and more we need a health systems approach where we consider HIV patients that can have other conditions, and we train our personnel, health providers, to be able to tackle jointly all the problems that one single patient presents. So I think that, again, integration of care, integration of education of our health providers, and also trying to strengthen the health system in a horizontal manner is the best take that we can have from the research that we are developing now.
That's excellent. Mayowa, why don't you come in just about a minute or so, share with us the role that biology, genetics, genomics play in all of this. It's very clear that we know enough, as I've said already, to address many of the challenges that are driving the burden of disease. But what role would genetics, genomics play from some of your work in H3 Africa? And if you had a minute to give us one message, what would that message be when it comes to burden of disease in Africa?
Thank you very much. Genetics has a very huge role to play. We all know that all of these conditions we are talking about, obesity, hypertension, dyslipidemia, stroke, diabetes mellitus, they are an interplay between nature and nurture. In fact, some individuals will tell you, well, I don't eat well, but it's not because I eat so much, but in my family, it runs, we are always obese and all that. So we need to be able to really quantify this. And some stroke patients will ask you, what's the risk or chance that their children would have a stroke? They actually want to know, but this can be quantified. How can we quantify this? Through genomics, through transomics, through polygenic risk scores. But polygenic risk scores alone cannot stand alone. We also know that the environment contributes a huge chunk. Modifiable risk factors that are inherited, environmental, that are not inherited, they contribute a huge chunk. So this can also be quantified using riskometers. In fact, we've come up with the first Afrocentric riskometer for stroke using the data we got from Siren, and we're also doing a similar thing for hypertension. So we could actually predict whether someone is going to be hypertensive, and of course, maybe more drastic measures will need to be put in place. So holistically, we can use these tools to predict. And these can be very, very potent tools integrated with motivational tools for intervention for primordial as well as primary prevention. So I think this is where genetics really have a very huge role to play. Of course, in the future, modification and gene therapies may come to play. But at this time, I think it could be something that could intensify the impact of behavioral modification when we are able to holistically predict and say, oh, you have a 40% chance of developing stroke. If you do this and that, you will reduce it to 20% chance, something like that, you know, and that will really ring the bell.
That's excellent. I think our time is almost up, and so we're going to have to stop, but I'm going to give Aime one chance because we were so delighted when we're able to have him join us. Very often we don't get Francophone countries to participate. So maybe, Aime, if you had one sentence, en français, monsieur, en français, just for the audience who speak French, what would you say? And make it simple so that all of us can understand.
Alors, merci Georges pour cette opportunité de parler en français pour donc les auditeurs africains francophones. Ce que je dirais, c'est que les maladies cardiovasculaires ont été négligées pendant des décennies en Afrique et avec l'apport de et un peu plus de moyens mis en jeu par certains gouvernements vertueux, on a une montée en puissance de l'épidémiologie des maladies cardiovasculaires. Il y a de plus en plus de malades cardiaques en Afrique et qui nécessitent une prise en charge qui aujourd'hui, dans le monde, est assez codifié et assez performant. L'Afrique doit prendre le temps de l'histoire pour s'arrimer et non seulement réduire les facteurs de risque cardiovasculaire, explosion, mais également mieux traiter les malades cardiaques, surtout en prévention primaire, car on sait qu'on n'a pas assez de moyens pour la prévention secondaire quand les malades sont déjà malades et très malades. Et dans le domaine de la rythmologie, qui est mon domaine de prédilection, Là encore, c'est une politique qui est davantage négligée, mais aujourd'hui, on se rend compte que les malades cardiaques souffrent aussi de troubles du rythme cardiaque. Les troubles du rythme cardiaque aujourd'hui sont traités de manière définitive par des techniques invasive. Et cette technique invasive demande beaucoup de moyens et les pouvoirs publics doivent mettre ces moyens pour qu'on puisse traiter de manière définitive la fibrillation, le flutteur, mettre des pacemakers, parce que quand on met un pacemaker, on soigne le malade de manière définitive. Or, il y a encore à peu près 20% des pays africains qui n'ont pas la possibilité d'implanter des pacemakers. Et même dans les pays où on implante des pacemakers, beaucoup de malades n'ont pas les moyens pour pouvoir s'offrir cette procédure qui coûte quand même beaucoup d'argent en Afrique. Donc, l'Afrique évolue. Nous, les médecins, nous devons être aux avant-postes et donner la possibilité aux malades de bien se soigner et d'encourager les pouvoirs publics de donner des moyens pour que les malades soient mieux soignés.
C'est bien, c'est bien. Wonderful. Thank you very much. Ladies and gentlemen, please join me in thanking our wonderful panel. This has been terrific. We are a little bit over time, so I'm not going to summarize what we've heard, but I strongly encourage you to take a look at the video again and the additional materials that we provide. Again, a wonderful thank you to all of our panelists, and please join me also in thanking the Journal of the American College of Cardiology, the Institute for Health Metrics and Evaluation, and the National Heart, Lung, and Blood Institute, who helped make this possible. So thank you very much. And I look forward to seeing you when GBD 2020 comes out. We will talk again about Africa. So thank you and have a wonderful day. Bye-bye.
Bye-bye.
Thank you.
Thank you.